Vamos ahora a continuar y vamos a dar inicio a la conferencia denominada Electronic Record System y Challenges and Examples, que dicho en castellano voy a hacer Sistema de Información de Historia Clínica Electrónica, Desafíos y Ejemplos. Y quien nos va a dar esta conferencia es el doctor Zlatan Sabic. Él es senior público de información, especialista en información de sistemas. Él tiene una amplia experiencia en la utilización de los TICs, la tecnología de la información y comunicación en el desarrollo del sector público, con estudios de planificación estratégica, abordando temas referidos a la implementación de sistemas de información pública. Conocimiento, gran conocimiento y experiencia en análisis de sistemas comerciales, análisis de la mejora de productividad, diseño de base de datos, almacenamiento de datos, diseño de arquitectura de software, coautor de marcas estratégicas regionales de desarrollo de la administración electrónica, la Estrategia Nacional del TIC para Bosnia y Herzegovina, y la Estrategia Nacional del TIC de la ex República de Yugoslavia de Macedonia, como facilitador y revisor. Bien, sin más preámbulo y agradeciendo desde ya su presencia aquí en nuestro seminario, vamos a darle la más cordial bienvenida entonces a el señor Zlatan Sabic. Zlatan, buenos días aquí en el Perú. Estamos ya con Zlatan.
Good afternoon.
¿Cómo está? Buenos días todavía por acá por Lima, Perú.
Yes, it's good afternoon from Bosnia. Thank you very much for this kind of introduction. As you mentioned, I'm working as a public information system specialist in the World Bank. And also, as you know, the World Bank is supporting a lot of health reform projects around the world that include digital health. And also, we had the opportunity to support many countries in the actual implementation also of electronic health record systems. So we thought it would be a good idea that we present you with some of our experiences and also some challenges that we have noticed, in terms of the actual implementation of electronic health records.
Muy bien, doctor Zlatan, gracias. Le reiteramos nuestro agradecimiento de parte del comité organizador. ¿Está usted en su casa? Ahí le dejamos este hermoso auditorio, así que adelante, por favor, y nuevamente, bienvenido a nuestro seminario. Adelante usted.
Thank you very much. You can hear me well, right? Do you hear me?
Se le escucha bien.
Okay. So as I said, we in our projects that we are supporting around the world, we noticed, that there are really some challenges, and there's really some things that government has to have in mind, when going into that adventure we call electronic health record implementation. I listened to part of those first two presentations, and it is so obvious, how electronic health records are actually good thing. There's many good things about it. There's a lot of value can be delivered with the properly implemented electronic health record. So the question, that I'm constantly asking myself is, okay, if it's so good, why everybody don't have it already? Because technology is everywhere. There are no local parts of the world anymore. World is global. Technology is available, and still good implementation of electronic health record is still more exception than the rule, not only in developing countries but also in developed countries. So. I found it also, in my experience working on these projects, I found it also useful that before starting working on electronic health record, it is always a good idea to really clarify what are we talking about, what do we want to achieve, and so on. Unfortunately, terminology on in this area is not fully standardized, and you can hear terms like electronic health record, electronic patient record, medical record used interchangeably and in a confusing way. So it is a good idea that we first clarify, this basic terminology to understand what are we talking about. So first important difference that we have to understand is the difference between so-called electronic medical record and electronic health record. May sound trivial and obvious, but very often not understanding this difference leads to a lot of misunderstandings and problems. So when we say electronic medical record, we usually have in mind, the detailed patient medical and treatment history that is usually in the office of the doctor and is very specific for that office or for that facility or for that practice. On the other hand, electronic health record is a kind of extracted data set that contains patient medical parts of the patient medical records from different doctor offices and different facilities. And its purpose is not to provide a detailed, history, treatment, and so on, but more like a holistic view of a patient. In a previous presentation from Israel, I think I heard that this also means that we have to be careful, what exactly to extract. Not too many details, only data that is important. These two terms should be differentiated from another term that we usually call master patient index, sometimes patient registry, which is a kind of mechanism or database that allows you unique identification of patients across different systems and across different levels of the care and so on. Sometimes in a country, you do have good mechanisms that provides you good identification. Sometimes you need something like this on a facility level or a regional level or something like that. In any case, master patient index does not contain medical data, clinical data. It is the mechanism for the unique identification of patients, which allows at the end the data exchange and connecting the different medical records around. And all three is different from so-called registries. The registry is usually the term that we use to describe a data set or data sets that are intended to collect uniform data for the very specific purpose, for a specific outcome of the population or healthcare. For example, cancer registry is a registry. So it is still a kind of electronic record, but very specific purpose. In this case, cancer registration. You do also have, communicable diseases registry, non-communicable diseases registries. Recently, every country has like a kind of COVID-19 registry and so on. So first thing to have in mind in thinking of strategy, how to implement electronic health records should be a kind of big picture. How these records and these databases function together. The electronic medical record at the providers that can use the central one master patient index, or they can have their own local identification of patients. Electronic health record that can be one national, or it can be on a different levels of governance or for different purposes. And registries, typical public health registries, etc. In addition to that, to make it even more confusing, sometimes you hear PHR, which is like a kind of personal health record, usually in a form of a mobile applications where patient access all these databases and it makes a kind of virtual picture of his or her record containing the data that the person wants to see. Another thing that needs to be emphasized here is something mentioned also in the Israeli presentation. This data exchange, data from medical record that is like going to health record, can be physical transfer of data, copying data from medical records to electronic health records, but that can also be a kind of virtual aggregation of the data, where the data physically does not leave electronic medical records around, but you can get a logical picture, online by pulling, the data from medical records as needed. Similar architecture also functions, for example, in Estonia, but in some other countries, we see physical copying of the electronic health, of data to electronic health records. So, in addition to those basic, to be clear with basic terms and understanding, these different databases around and terminology, there are, in our experience, there are really three fundamental things that one has to have in mind before starting really implementing the electronic electronic health record. First one is the scope. We have to understand the purpose. Why are we doing that? Because implementing electronic health record is a large effort usually, and you don't do that, just because you want. You have to understand the purpose. We'll come back to that. Second determinant is to set up a proper environment for the electronic health record to be implemented and also to be used. We'll see later, electronic health record is really not one project. It's more like a process and a long-term adventure and long-term effort. So to do something like that, you need to have not only resources, but also kind of proper environment in which you can implement and use EHR. To understand the scope, to have the proper environment, it still doesn't mean it's going to be successful. It's still, you need to spend some effort and time in, governing the process and pushing the EHR implementation and use. So we'll go one by one, and I'll try to emphasize the challenges that we have encountered in many projects so far. So first one is scope. I'm sometimes surprised, to really see that the fundamental thing, why are you doing something, is sometimes not clear. In some countries, if you ask very simple question, okay, you're planning big project and I don't know how many millions of dollars to spend for this, what you call electronic health record, and why? Sometimes it is hard to answer that question. Sometimes answer is, why not? Sometimes answer is, well, we can exchange data. Why not collect them, so we can see everything? But when you ask another why, why would you want to see everything? Sometimes it's not easy to respond. For example, one of the determinants is like a patient mobility. So if your reason for electronic health record is that you have information on a patient, if patient goes from one hospital to another hospital or from primary care to hospital, you can ask yourself, okay, do I really need that? I mean, on the territory of the whole country, like in the question, if you talk about like big countries like United States or Canada or Soviet Russia or the countries with tens of millions or hundreds of millions of persons and very distributed healthcare system, you have to ask yourself, okay, how many times actually it happens that the patient moves from a hospital in California to hospital in New York, And is it worth, to have national health records to exchange all the data constantly only for purpose of this small percentage of patients moving around? For example, questions, how quickly you need to access the record? Should it be online or some sort of transfer, offline transfer is acceptable, and so on and so on. Many of those questions are also related to the question for whom you are doing it and who will be using health records. So usually we talk about the nationwide or countrywide health records, but not necessarily. I mean, these can be regional, or they can be connected to some provider networks or insurance networks. Even big facilities like big hospitals have their own records. So just a few examples. For example, probably you all know about the kind of bad Canadian experience, trying to push a big, huge, multi-billion project of electronic health record on the whole territory of Canada. And it turns out that it's not only challenging, but also not necessary that you do have electronic health records that covers a whole territory of Canada. So what is happening now is something more realistic, that provinces in Canada are having their electronic health records, like Quebec, 4 of those, Alberta and Nova Scotia and Saskatchewan. On the national level, more like public health or indicators are needed, public health statistics and so on, not really through electronic health records. So we'll see how that develops, but it seems that there's really no need to have national health record in Canada. There's another example that is the opposite. This is architecture from Saudi Arabia. And Saudi Arabia does have technical infrastructure and unified electronic health record on the national level, because there is a need. In Saudi Arabia, there is a centralized government, but decentralized healthcare system. There are sectors such as education, defense, Ministry of Internal Affairs. They're having their separated healthcare networks and their own medical records and electronic health records. So there's a need for that country, that on national level, they have a proper electronic health record with the data that is needed for policy making, decision making, and data exchange. This thing goes well. The Kingdom of Saudi Arabia invested a lot on technical architecture, and also so this effort moves pretty well over there, even though the health record is still not fully filled in and functional. We'll come to that later. This is an example of Ukraine. For example, Ukraine is the example of the country where central level doesn't have proper capacity to run everything that is needed for the national health record. So what is happening is in Ukraine is that regions, they call it oblasts, are actually developing their own infrastructures for the use of electronic health records. And then part of those data sets are shared on the national level. This is an example of a facility that has similar structure. Even one hospital, like this is Beijing, this is the block scheme of the information system of the Beijing University People's Hospital. So this hospital has health record, has different medical records, about 70 systems, clinical system working around, master patient index, and so on. So this hospital itself is like a small country, which is not surprising. This is Beijing, and the biggest hospital in Beijing, and they have more than 3 million visits per year, which is comparable actually to a country. Second thing that is very important, and that was already mentioned, I think, in Israel's presentation. I'm not sure about the previous one. I wasn't looking for the whole presentation. Is the regulatory and standardization framework. So what typically happens around is that the country really doesn't have one health system, health information system. There's a lot of those electronic medical systems in primary care, hospitals, laboratories, emergencies around, but also other related systems like such as pharmacies, blood management, and so on, that grow around like mushrooms and computerize some clinical functions. To put that together somehow, you need a kind of central coding systems like ICD coding, central registries, you know, of providers, central registry of professionals, etc. So all those systems, if you want them to be interoperable, they have to use the common coding from those registries. Shared electronic health record is also one of those central systems, but also some common central applications such as e-prescription, e-referral, and so on can be on that side. And then you need some sort of mechanism that is allowing data exchange between all those systems on a coordinated and organized and standardized way. As I mentioned, you know, this data exchange can be virtual, you know, so this layer can be a kind of messaging system, but also it can be a physical copying of data around. To have this working, you have to put it all into some sort of regulatory and standardization framework. So this, somebody said it's a long-term process, a little bit complicated, but not necessarily in the beginning. We supported one project in Kazakhstan that triggered, you know, this kind of development of this kind of architecture. So in Kazakhstan, they started with a very simple standardization framework, like 2 standards in the first year plus 8 standards in the second year. Just basic, you know, fundamental standards, and half of that was just a copying from already existing ISO, HL7 standards, and so on. What was more important actually was that they put together good governance structure that can work on this constantly. In Kazakhstan, this was on three layers. On the policy layer, which is the technical committee for electronic health standardization, and a little bit bigger, so-called health information center that is managing coordinating and managing the most of the implementation around. So our experience is to not start with a too complicated standardization framework, because you will lose, you know, the purpose. You know, you'll start spending too much time on standards just for the sake of standardization, losing the objective. But what is important is to put together proper governance structure. If this implementation depends on a group of enthusiasts or you know, volunteers or a very small group of people involved into that, without proper institutional involvement and governance, usually that doesn't work. Usually this is too short. Even if a country puts everything together, or almost everything together, it's still not the guarantee that the EHR will be used immediately and filled in immediately. We have a lot of examples of efforts, like for example in Romania, all technical systems were implemented and everything is set up properly. Romania invested more than 100 million euros for that infrastructure, but still after several years the EHR was virtually empty, because there was no proper regulatory framework that is pushing the providers to share the data, but also incentivizes the providers to share the data. Because the question is, yeah, we all know the good things about the electronic health record, but if you're a hospital, if you're a primary doctor, private primary doctor like in Romania, what is the incentive for you to really share the data? You know, so So usually you need to have kind of stick and carrot mechanisms to really make the use of electronic health record very wide. Similar, Kazakhstan, as I said, I think that Kazakhstan did everything right, but still after like several years, there's only about 50% of data shared. And right now I know that Kazakhstan is preparing another project, another push, to make the utilization of the electronic health record better. In this case, we see there's still inertia, and also there is one thing that not all electronic medical records are ready. So this is why data cannot be shared. I will come back to that later. As mentioned, Canada, that couldn't work because it was questionable what is actually really needed at, and it was simply too big. If it's too complicated and too big, it's not going to work. So let's see this issue with the medical record I mentioned for Kazakhstan. So if you don't have electronic medical records in providers, the only way to fill in the central registries, for example, public health, including the electronic health record, is to manually enter the data from reports. And this discontinuity is the major source of the low quality of data, mistakes, incomplete data sets, and so on and so on. So in principle, ideally, you should really not think about electronic health record if you don't have electronic medical records. In reality, it is hard to wait, to have like 100% of hospitals and 100% of primary care computerized and have proper medical records to really start extracting data to electronic health records or public registries and similar. So there should be some compromising here, but one that implements electronic health records should bear that in mind. That non-computerized medical records, if these are paper records in doctors' offices, will be hard to be included in the electronic health records. Therefore, to push, so you need to understand the scope. You need to understand, of course, technology, invest, put together good environment, technological environment, and also standards and regulatory environment. And still, you need to do some push. For example, one of the issues is how to adjust electronic medical record systems in hospitals in primary care to the share of data share with electronic health records. One of the mechanisms is presented here. For example, what you can do, you can say that government creates standards and regulations, which means functional requirements and technical standards and data standards to allow medical record systems to exchange data with electronic health records. Then the government calls ICT industry, the software providers, to certify their solutions to those standards. So they can certify that their EMR system, for example, for the hospital or I don't know, pharmacy system or a laboratory system can exchange data with the electronic health record through that, according to those standards and regulations. And then government can incentivize the health facilities with money or some other incentivizations, to purchase only certified solutions that can exchange the data. So that way, government pushes, and incentivizes the use electronic health record through the standardized environment. This is famous Estonian example. As you know, Estonia is very successful in using EHRs and in general digital health development. I just wanted to show this graph to show that even if things don't go well at the beginning, one should not be too much disappointed. With a lot of investment into this environment, standardization, and everything else. Still, in Estonia, as you can see, for several years, the use of electronic health documents was not really high, and the trend was not really promising. But this is like I'm sorry, this moves constantly. This is like but this thing feeds itself. More electronic documents, electronic data that you share and allow to share generate as a positive feedback, loop. It generates more need and more requirements for the electronic data exchange. So at one moment it started growing exponentially, and in a few years Estonia reached really high numbers in this sense. Finally, I can say thank you very much. I think I fit into 30 minutes. So to summarize, it is excellent to have seen those examples, especially I like this Israel example, because it sounds to me very realistic, and very not over ambitious and so on. Our experience is that these three things are extremely important if you want that. I wouldn't say it project, I would say the effort of implementing electronic health record is successful. To really understand and be realistic with your expectations and ambitions, you don't have to exchange everything about everybody. You can have much less expectations, but if you have a clear understanding what is the purpose, how do you get the value of that, then it's going to be successful. You need to provide the environment for this thing to grow constantly. The most important is a proper governance structure that is sustainable, because this is it's not the project. It's a process, of better and better use of electronic health records. And also, number three, it usually doesn't happen by itself. You cannot just put together environment, technology, and everything and just sit and wait that it grows. No, you have to take care of it. You have to incentivize. You have to use stick and carrot. For example, money is a good idea. For example, if some data sets are connected to payments by insurance or some other payer, you can say, okay, you don't get paid if you don't share this and this data set and so on. But also some positive reinforcements and that can come also from patients and again general public. If patients are asking for their personal records, then you are incentivizing actually the providers to provide proper data. So this is more about governance and more about approach, but in my experience, that's of crucial importance. Technology comes after this. Thank you.
Muchas gracias, señor Zlatan, Sabic. Le habla el doctor Juan Rodríguez. Estuvimos coordinando su presentación. Gracias al Banco Mundial que ha permitido la participación del señor Zlatan. Más bien, discúlpenos un poco el retraso, cosas del programa, pero ha sido muy provechosa su participación con toda la experiencia que nos ha mostrado. Resaltar uno de los puntos, entre todo lo valioso que nos ha comentado, es el tema de los procesos, ¿no? Los procesos, todo sistema de información responde a unos procesos y es un poco que quizás ese concepto vamos a aplicarlo después de almuerzo con los grupos de trabajo. Más bien, nuevamente, lamentablemente el tiempo nos ha ganado. Simplemente le pediría que nos pueda compartir su presentación, o creo que ya no la remitió, ¿no es cierto? Entonces la compartiremos con el público asistente y gracias nuevamente a usted y al Banco Mundial por este apoyo en este evento. Un aplauso nuevamente para el señor Zlatan.
Thank you very much. I hope it was useful.
Siempre con el pueblo. Gobierno del Perú.